of you to this webinar. We are very excited to see this happening. This has been in the making for a long time. I specifically want to thank our three presenters for being available to participate. And so the Child Survival Working Group, which has been helping to organize this and co-facilitate, is really grown out of the HIV community. And, we talked about TB HIV and realizing that, the Childhood TB Global Working Group is facing very similar challenges and problems. And we really wanted to talk more about TB in the broader context of maternal and child health, looking at the continuum between mothers, infants, children, and then adolescents, get a broad overview, which Steve will give us, and then country experiences from both Uganda and Kenya. We hope that we will have time for discussion. We look forward to hearing from all of you about your thoughts and experiences about opportunities, challenges in the field, and how maybe as HIV and TB community we can work better together. So I want to introduce our first speaker, who's Steve Graham, a professor of international child health with the University of Melbourne. He's a pediatrician with clinical experience in many resource-poor settings over 20 years. He's a founding member and former chair of the WHO Childhood TB subgroup and a member of the Strategic and Technical Advisory Group on TB for WHO. He also works as a child lung health consultant for the Union and provides technical assistance, training, and support in operational research to countries in the African and Asia Pacific regions, as well as support to many, many national TB programs across the world. So, Steve, thank you, and over to you. Steve?
Sorry, I just unmuted. So thanks very much, Anna. Thanks for this opportunity, and I've been given the task of covering a wide spectrum. So I'm just going to do a rather overview of what I think are some of the issues and touch upon them as I go through. I know I have a lot of slides, but you're very welcome to use those slides, and hopefully you'll be able to highlight some of the issues as we go through. And I mean, I think that until recently, there's been a lot of talk about the neglect of TB in children or TB in infants, and I would say also pregnancy-related TB, adolescents TB, and hopefully this is now starting to change as we've moved from a focus on control of infectious TB to a broader TB control addressing more vulnerable populations. With the Stop TB expanding in 2006 and more recently the NTB strategy, I think provides arguably the best opportunities to address some of the more neglected areas in these vulnerable populations. So I think the Child TB Roadmap, I just wanted to focus on a presentation that brings out a few of the issues through the talk. I was recently in Da Nang in Vietnam, and there was a presentation on twins at 3 months of age who both presented with severe pneumonia, not responding to antibiotics, not at the same time, but only 2 weeks apart. And these are their chest x-rays. And because of the chest x-rays and the non-response to antibiotics, people started to think of TB, so they did gastric aspirates. And both of these children ended up as expert positive, bacteriologically confirmed tuberculosis. And though it wasn't initially given in the contact history because of reluctance to admit the situation, it came out eventually that the father actually had smear-positive TB and had been on treatment for some months, and that the mother had had TB effusion around the time of pregnancy. And I think that and I think that they brought out a couple of issues. Is what we know is the age-related risk of TB. These were very young infants. Both of them ended up with TB disease. The clinical overlap with severe pneumonia, where TB can often be missed. The history of contact, which is so important, but which can sometimes be difficult to tease out, given the stigma associated with the diagnosis of TB. and the missed opportunity that both of these twins had when their parents were diagnosed with TB of having preventive therapy and not developing disease, and the pregnancy-related risk of TB, as was the case in the mother. And in Vietnam, there's actually, as I'll highlight a little bit later, a problem of the TB burden in children is really very, very low. It's been up to less than 1%. But one of the problems is underreporting, and neither of these twins were actually reported to the National TB program, despite having bacteriologically confirmed TB. So, I'm trying to get this, yeah. So I think some of the issues around that were highlighted by the roadmap are really important to emphasize. And I think that the roadmap was published in 2013, and one of the things that it tried to do was to reach out to the child health community and try and bridge the gap between the silos of the child health, maternal and child health community and the TB community, and try and start them to work together in the sort of context of child TB working groups, if you like. And I think that the steps required are still the steps we need to address now. And I think I think in this talk I'm also going to try and emphasize the importance of adolescence. The child TB subgroup, of which I used to be the chair of, is now the WHO working group for child and adolescent TB, and I think that's a really important step in the right direction. I think we're trying to now embrace adolescents in the context of tuberculosis, and I'll show why I think they're an important group. And in terms of adolescent health, it's always been left to the child health people to take up that mantra and start to move in the context of adolescent health. So that's important. So I'll just start to. So first off, we have improving estimates. First estimates in 2012, much smaller numbers than were estimated in 2015. I think we're improving the estimates of the burden of child TB globally, thinking that it's now around 10 to 11% of the global caseload. Large numbers of deaths of TB in children, and I'll come back to that later, including in HIV-infected children, and still underrepresentation in notification for child TB by national TB programs. And I think most of you would recognize that depending on the setting, the challenge is whether is this a case of being underdiagnosed and underdetected, or is this a case of being underreported? And this very much varies hugely between countries. So in the setting where I'm in Western Pacific, we have, for example, in Vietnam, a very small number of children being reported to the programs. Whether that's under detection or under reporting, we still don't really know. The same as in Laos and other countries in the region. In Papua New Guinea, which has a major TB epidemic, you would think by looking at the recent report from WHO that child TB is not a major player, but they only report smear positive cases. And the actual proportion of child TB under 15 in Papua New Guinea is actually 26%. TB is the major cause of hospitalization for children in Papua New Guinea. So it's a major problem in that particular part of the world. Cambodia has given a large, given a lot of attention to child TB in recent times. So that may be one of the reasons why they have a bigger representation than other countries in the region. And there may be a tendency to overdiagnosis. And so there's a whole lot of variability that's going on, and there's a lot of uncertainty still. In MDR-TB, there's even more uncertainty as to what is the real burden, but we suspect that MDR-TB in children is likely to be as prevalent in children as it is in adults, meaning that in countries or settings where MDR-TB is common amongst adults, it's likely to be very common, and that's also the case for XDR-TB. And so I've listed there a number of the challenges, which include lack of child-friendly formulations, and also children being at the moment still excluded from access to new drugs, particularly young children, for bedaquiline or delaminid, not because we think that these drugs are more dangerous in children, but because there's just not enough PK or safety data to be able to get the regulatory authorities to include them. So these are challenges. So in terms of trying to put child TB onto a sort of public health agenda, I think our view has been for some time that we need to emphasize its importance in terms of child mortality. Everybody recognizes child mortality as a major public health priority. Most countries have that as an important issue that needs to be addressed, but very few countries, including TB endemic countries, recognize the contribution of TB to child mortality. So I think some of these recent estimates are really, really valuable in terms of emphasizing the numbers of children dying from TB. Most of the children dying are under 5. Many of them are in just a couple of particularly high TB endemic regions, and most of the children who die probably don't get diagnosed and receive TB treatment. So you can see their case fatality rate estimates. If a child receives TB treatment, we know the outcome is often very good, but many children don't. And in that context, obviously the mortality is high, particularly high if they're under 5, or particularly high if they're HIV infected. And here are just some data from WHO on the global burden of TB in women. And there has been some estimates of child TB in pregnant women, but unfortunately those estimates didn't account for the fact that there may be an increased risk around the time of pregnancy for women compared to when they're actually not pregnant. And so in terms of TB in pregnancy, we also have to think about, in terms of adolescents, how much including, we know that the numbers of TB cases increase in the 15 to 19 years of age. Is pregnancy in teenage girls a contributor to that? We have absolutely no idea, but we do understand that late pregnancy or pregnancy-related TB is a particular issue. We understand this particularly well in TB HIV infected women, but we know that TB HIV in pregnancy is associated with TB mortality or maternal mortality. We know it's associated with preterm births, with low birth weight infants, with infant morbidity and mortality, but we don't have a lot of data about the impact of TB-related pregnancy in HIV uninfected women. Though there has been one study from the UK that did find a significant increased risk of TB in pregnancy, comparing women when they were pregnant versus the same women when they weren't pregnant, with a risk that was similar to what is associated with diabetes and tuberculosis, almost a twofold risk of tuberculosis. So adolescents, few data, and this is something that we're trying to address. WHO reports 0 to 14 and then 15 to 24, so it's very hard to get a handle on the 10 to 19-year-old age group. But it's interesting, for example, this study from Western Kenya, when they actually did a prevalence survey, they found a very high prevalence of 680 per 100,000 compared to what was the notification rate for the same region. So over 6 times higher in adolescents than was what was being notified to the region. So adolescents, just to hang on this a little bit, it's hard to tease out what are the data, and there's various definitions of what's an adolescence. But the important thing from a TB point of view is what we need is a breakdown by 5-year age group categories rather than 0 to 14 and then 15 to 24 to try and get a better handle on what's the burden of TB in adolescents. And we know from data from the early part of the 20th century that the adolescent age group is a risk for an increasing numbers of TB cases. And that's been established for some time. Why that is not absolutely clear, whether it's relating to biological changes during puberty or other risk factors, but it is an important and neglected group. And if you look at this data from South Africa of TB in children and adolescents, again, you can see it, that the 15 to 19 year age group particularly amongst females, whether that's better access and case notification, or whether it's earlier acquisition of HIV or various other things, we don't really know. But this is an important group that we need to understand better as to what's going on. And adolescents in TB endemic countries represent a large proportion of the population. And the important thing is also to recognise is that adolescents are often infectious, and so they contribute, unlike young children who have often been neglected because they don't contribute to transmission in the community. Adolescents are an important source of transmission in the community. So there are many challenges for adolescents and adolescents with TB and TB HIV. They fall between the cracks in terms of health services, between child or adolescents. There's issues around treatment support and adherence. There are some studies that have shown that treatment outcomes, they're one of the high-risk groups for poor outcomes because of poor adherence, for reasons we understand about adolescents. And there's also the fact that they go into schools and tertiary institutions, and there's a huge problem of infectiousness and transmission in those particular settings. And adolescence is also a time when there's an increased risk of comorbidities that are very important, not just HIV, but also other comorbidities. And in the African setting, I know that chronic lung disease in HIV-infected adolescents is a major issue with how much of a role does TB play in that particular scenario is still not well understood. So just to sum up so far, I think we have been trying to emphasize TB in the context of maternal, child and adolescent health because it is a major morbidity and mortality in that context. It's not just about TB control and TB transmission, but it's also a major contributor to maternal, child and adolescent morbidity and mortality, both directly and also indirectly. If you think about the numbers of orphans who will have the consequences of losing a parent from child TB, or indirectly from the economic costs of families living with TB. So I'd just now like to move on to some of the other issues around diagnosis, treatment and prevention just quickly. We understand the risk groups for TB disease in children very well. We recognise the high risk of very young children, but we also recognise the risk of adolescents or early adolescents in this stage. We know that BCG has probably reduced the risk of disseminated disease, but less so the risk of other forms of tuberculosis. And this emphasises the challenges we have for diagnosis, given that that's often in very young children who are hard to get bacteriological confirmation, but it also emphasises the rationale for preventive therapy in focusing on young children who are child contacts. what this slide really is just trying to emphasize is that in the groups that are the hardest to make a diagnosis of bacteriologically confirmed TB often, but probably most important, these are also the high-risk groups for mortality in terms of TB-related mortality in children. So I would argue that we have now arguably the best opportunity we've had for some time. Thanks, Anna, for the 4-minute. Yep. In terms of addressing the issues around child TB, we moved 2006. We moved to vulnerable populations, which included children in the Stop TB strategy. But more importantly, we're now in the NTB strategy, and there's much more focus around these particular pillars, which now I think include children, particularly prevention, which gives us an opportunity that we need to embrace. So in terms of diagnostics, rapid development diagnostics happened in the end part of the 19th century, but we're now talking about the development of rapid diagnostics, and we've still got a lot of work to do. The expert is an important advance, but there's really still a lot that still needs to be done to improve in terms of point-of-care diagnostics for children. The expert and then the expert ultra, which is an improvement upon the expert, cannot be used to rule out TB. It still probably has a sensitivity amongst all children with presumptive TB in children at least of only around 30%, around 60-70% compared to culture, less in outpatients. In programmatic use in India, for example, with fine support, it's still getting only a yield of around 10%. So I think it's particularly useful for children with presumptive MDR TB because it gives that rifampicin resistant result, but it's not the answer necessarily to being able to rule out TB in children. And I've just referred to the fact that there is the Expert Ultra, which will perhaps be similar to culture in terms of sensitivity, though there needs to be studies in children. But I think still there's a lot of children that still need clinical diagnosis. And in that context with the union, we've been trying to develop job aids for training and free online training, etc., that some of you might be aware of, and I would recommend you to the Child TB portal has just been launched recently with trainings on child TB, child MDR TB, and a list of toolkits and resources to help strengthen diagnostic challenges for the healthcare workers. One thing that's brought a lot of energy into trying to address the issues of child TB has been the introduction of the new fixed dose combinations. These are now being rolled out in more than 60 countries with orders for more than 400,000 children for treatment, which I heard today from TB Alliance, which is great. And this is definitely an important step forward in terms of treating children for TB. And so the other aspect, of course, which is really important, and just to finish up, is prevention. And I've recently argued that I think there's never been a better time to try and take on some of the issues around prevention in terms of political will, in terms of shorter, simpler, safer regimens becoming available, and in terms of evidence emerging from decentralizing the whole business of doing contact screening and preventive therapy from a central facility-based level to a more community integrated family-based approach. And I think what we need more and more of is evidence of cost benefit, which is really important and I think potentially extremely compelling in terms of making the case for that. It's encouraging that WHO is now starting to try to report on the coverage of preventive therapy. it is an important indicator for the future, and I think this is. But you can see from this slide that at the moment coverage is not high. But this is still a top 10 indicator for monitoring the implementation of the NTB strategy is coverage of actually household contacts and preventive therapy. So these are important goals, very difficult, I think, to reach these targets, but at the same time, I think this shows the political will at the moment to improve prevention. What we really need is a point of care test that we can use in the field to distinguish between infection and disease, somebody who can exclude disease but at the same time is infected and get the right treatment. I think we're still a long way away from that, probably at least 10 years or more, but I think there is a lot of work, an increasing amount of work being done in this, and so that's quite important. I think another area that's really important to give momentum to the whole issue of prevention is the possibility of shorter, simpler regimens that are equally as effective. And one of those that's now available for the fixed dose combination is 3RH, a fixed dose combination of rifampicin and isoniazid for 3 months, there's plenty of evidence to show that it works. WHO has now got an LTBI task force to update these guidelines for the low and middle income settings and TB endemic settings, which will come out soon, and there'll be new recommendations around alternative options for preventive therapy beyond six months of isoniazid or more. There's a need for, and this is happening more and more in countries, about trying to monitor for the cascade of care in terms of rolling out preventive therapy and contact screening. And I would add that we don't just need numbers of adherents, but the numbers of who develop TB. So I've been told to round up. This is examples of community engagement, which are really important. This is from Vietnam. It's not easy to convince families that their healthy child needs a treatment or a medicine for 3 or 6 months or whatever it might be to prevent TB, and this is an area that needs a lot of work and to help support the community health workers, and I think also an area that we're still struggling with is the management of MDR TB contacts. We have some evidence that there are medicines such as fluoroquinolones that will be effective, but the evidence is not strong. But at the same time, the benefit versus harm, outweighing the harms with reasonable confidence, which is your WHO guidelines, I think provides a very compelling case, in my view, that we should be giving preventive therapy for young, high-risk children who are contacts of MDR TB to prevent the consequences of developing TB. Because I think that we do understand that this would be safe and that it has no impact on propagating resistance for XDR, for example, which are some of the concerns that are out there in the community. So I think there is a very, very strong case to start to implement preventive therapy for young MDR TB cases. So this is my summary. I'm trying to wind up. Maybe I should just leave the slides. I think this is just a summary of some of the issues that I've just highlighted, and this is some of the opportunities as well. So I think in terms of summarizing the opportunities, there is bigger opportunity than we've had for some time. I think that there is increasing awareness of TB in the context of child mortality and integrated processes in maternal and child health. And there are targets now being set. There are shorter, safer regimens for treatment of infection. The prevention of MDR TB in contacts is compelling. And so I think there's huge scope for operational implementation research. But I think there's great opportunity now to improve the management and prevention of child TB. Thank you. Sorry for going over time.
Thank you so much, Steve. This is Surbi Modi from CDC, and on behalf of Anna and myself, I wanted to just thank you for that very comprehensive and informative overview of TB along the life cycle. I'm sure there are many questions, but I'm going to ask the participants if they can start typing their questions into the chat box. We're going to move directly to our next presenter, and then we'll have time for question and answer after our next two presenters have shared their experiences. So first, we'll be starting with Dr. Maureen Cascade. She's the National more than 7 years of experience in TB care and prevention, specifically with childhood TB, in both public and private care settings. Dr. Cascade's primary area of research has focused on epidemiology and diagnosis of childhood TB. Maureen, over to you. Thank you.
Today, as mentioned, I work with the National TB and Leprosy Program in Uganda, and I'm excited to share Uganda's experience in addressing TB along the life cycle. I want to appreciate the organizers for this webinar and for giving me this opportunity to share our experience. So I will start with the first slide that really highlights the different critical points that we can use to address TB along the life cycle. And with this, we all know that TB exposure in early infancy is a reason for adult TB. So this schema just highlights the different areas that we as programs, as healthcare workers, as stakeholders can use to integrate TB services along the cycle. Then I will move on to share what Uganda has gone through while addressing tuberculosis. We have actually used childhood TB as the entry point to addressing the TB problems. And I must say that it starts with recognizing the problem. And in here, we know that use of data is very important to really guide the decisions to take. So we have conducted multi-level coordination, and this includes having a focal point at the National TB Program. We have worked with the established Ministry of Health structure that comes from national level, regional, district, and health sub-district. And along these levels, we have worked with the different stakeholders that also work with the different programs. We have also had multi-level stakeholder collaboration, and this includes the consultations, policy development, planning, implementation, as well as resource mobilization. So I just wanted to flash a schema of our Ministry of Health structure that really highlights the different programs that have been used to integrate childhood TB and in a way address TB in the different life cycle areas. And it's very important to map out the different programs because these are the people that we will work with or we have been working with to address the needs and TB areas in the country. So stakeholder mapping is very critical. The other implementation approach that we have used is really phasing the implementation. We started with a baseline assessment, and this was very critical in helping us document the gaps that have been used to improve the TB service delivery. And evidence is very critical. When you go on to approach a stakeholder, what they will ask you is evidence, evidence, and evidence. So it is important to document the gaps, and these are the things that will be used to really drive the agenda. And the findings were also used to inform our roadmap that we use to scale up quality TB services, addressing the different care points. We have been able to draft national policy and guidance documents, and these have also emphasized integration at the different care points. We have also been able to conduct in-service, on-site capacity building activities, including trainings, and these have also focused on prevention, screening, diagnosis, and treatment. So we have taken the trainings to the service provider, and this really creates ownership, and you have a pool of health workers at the facility level that are able to manage the different cases, the different patients that present at the different care points. The other thing that we have done is to update some of our documentation tools, because this is very important in really tracking the progress. And specifically, we have included TB in our HIV documents. We've included TB in our antenatal care package. So these are very critical in tracking the implementation. The other approach that we have used is integration, which I already mentioned, and we have particularly used our lessons learned from TB integration, providing services at one care point. And this has included prevention, screening, diagnosis, treatment, follow-up, as well as recording and reporting tools. We have learned a lot from the integration of TB into HIV, and the successes are what we use to really back up our implementation strategies. The other innovations that the country has also taken on include the Detect Child TB project that was funded by the Union in collaboration with Ministry of Health and Baylor Uganda Mildmay. We have seen an increase in the number of cases of children that have been diagnosed with tuberculosis, as well as those that have been initiated on isoniazid preventive therapy. So this Detect Child TB project utilized a health facility arm as well as a community arm to actively find the cases of TB in children and those who are at risk that would benefit from preventive therapy. We are actually currently running a project on integrating TB and HIV into integrated community case management of childhood illnesses. And we have introduced a question that asks about risk of TB, in that every child that presents to a community health worker is asked, or the caregiver is asked, whether there is a history of a household TB contact and whether the child is at risk for HIV. And this is funded by UNICEF in collaboration with the WHO, and we're also working with the Ministry of Health and the different stakeholders. We also have the HOPE project, the headquarter operational plan, that is being funded by CDC through Baylor Uganda, and this is also bringing on board a very strong community component of integrating TB and HIV services. So the next slide just shows a schema of what we included in our job aid to guide health workers on integrating TB services. Apologies, it might not be clear, but the middle section just lists all the TB services, and this really comes from health education, screening, diagnostics, preventive therapy, treatment, HIV testing, and we also added a critical component that is a continuous quality improvement that has been shown to improve service delivery at the health facility level. The challenges that we have noted, I have divided this into health system, healthcare provider related, patient related, and for the health system, there is an issue of competing disease program priorities. Other programs have their own priority areas beyond tuberculosis, so that is one challenge that we have documented. And the other is that not all of our health facilities are TB diagnostic units, especially the health center tools, which are the lowest care points that the community will approach. So this is one thing that is important for us to improve as towards successful implementation of or improvement of TB service delivery in an attempt to meet the NTB's strategy targets. We do appreciate weak referral, linkage, and feedback mechanisms. both intra and inter-facility, and this span across referrals for diagnostics, referrals for treatment, as well as referrals for prevention. And we also appreciate that our current tools may not fully facilitate tracking of integrated TB services at all levels. So we are unable to completely track the integration and limited resources as well. For the service provider related challenges, we have learned that health worker attitude impacts on TB screening, and it's a critical issue that really needs to be dealt with. And then the other is a limited health worker knowledge, skills and confidence in identifying patients with or at risk for TB. And we have started working with midwives, really trying to bring them on board in providing TB services in the antenatal care point. We're working with staff in reproductive clinics. We're working with staff in outpatient clinics. So it's important to build their confidence in identifying the patients that need the services. The other challenge is the documentation and reporting errors, as this also impacts on the figures really that we report. For the patient and caregiver related challenges, limited awareness on TB generally, as well as health seeking behavior. We do have limited health seeking behavior among our community members, and that will impact on the demand generation as we provide the TB services. The opportunities to reinforce interventions include under policy and guidance, inter-program collaborations, and in this I wanted to highlight bi-directional policy adaptation. If one guidance is in the TB program documents, it's also important that this is included in the other disease-specific program documents, in that the health worker will keep seeing the same information across the board. The other is pre-service training before the health workers are enrolled into formal service delivery, multi-sector collaboration. As far as service delivery is concerned, the opportunities include integrated management of childhood illnesses, which is a strategy for child survival that is critical, because IMCI looks at management of pneumonia, you have malnutrition, and these are disease conditions that might present as tuberculosis. The other is ICCM, which has also shown us that you're able to identify children with TB and those who need preventive therapy. School health is one of another critical area that needs to be strengthened and can also improve in providing the cases or the children that are in need of the services. There is also a focused antenatal care package where TB screening is an important aspect that would identify mothers that would benefit from TB treatment. The adolescent-friendly services, Steve has mentioned, this is a critical age group with increased risk for TB, and the available friendly services are an opportunity for us to improve case finding among this age group. Contact screening has been shown to be effective, and there is also another strategy or opportunity that we can tap into to identify the children that need the services. Detect TB approach actually showed us that if you do the active case finding, it also improves case finding among the adults as well. Then we do have community outreach programs, including immunization, nutrition. So these are also areas that can be tapped into to improve tuberculosis case finding across the life cycle. The other approach is the continuous quality improvement approach that really spans across all care points and is an opportunity for us to improve the quality of services, and this results into improved case finding and those that need preventive therapy. And I would want to acknowledge the government of Uganda, the various stakeholders, the development, the funding partners, the community that have really supported us in improving TB services in the country. Thank you very much.
Thank you very much, Maureen, for this comprehensive and really interesting talk. Without further ado, I'm going to pass on to our next speaker while motivating all of you who have questions or comments to enter them in the chat box. So our next speaker is Dr. Herman Weyenga, who's a medical doctor and public health specialist at CDC Kenya. He's a technical advisor for TB HIV and member of the Kenya PEPFAR interagency team. And formerly, he was the head of care and national TB HIV coordinator at the National TB Program in Kenya. Welcome, Herman, and over to you.
Oh, thank you very much for the opportunity to make this presentation. I'm presenting on behalf of Immaculate Kadure, the pediatric TB focal person at the Ministry of Health National TB Program. Next slide, Adley. So I'll be talking about TB along the life cycle, and basically I think I'll be focusing on IPT in Kenya. So in Kenya, we have we've been implementing IPT for a while now, and the indication for IPT in Kenya is includes people living with HIV aged more than 1 year old, including pregnant women, children living with HIV aged less than 1 year but exposed to smear-positive TB or bacteriologically confirmed TB, and children aged below 5 years who have also been exposed to smear-positive TB, prisoners and healthcare workers. Next slide. So a bit of history about IPT in Kenya as a national policy. Going back to 2009, we had national TB treatment guidelines that were restricted IPT to people or children exposed to smear-positive TB aged below 5 years of age. But moving forward to 2011, the release of WHO guidelines, the 3Is guidelines, gave our program an impetus to rethink about IPT in Kenya. And in 2011, we started setting up pilot projects based on the WHO guidelines to see how we could implement IPT among people living with HIV. These pilot projects gave us very good results, and by 2013, we had to revise our guidelines to have a wider IPT coverage for people living with HIV, including pregnant women and children. By 2015, we had very good results from our pilot project, and this necessitated the development of IPT SOPs that would support IPT implementation nationally for people living with HIV. Next. Next slide, please. So these are some of the data collection tools that we have. We have an integrated intensified TB case finding and IPT record card. At the top of the card, we have TB screening questions. At the bottom, if someone does not have TB symptoms, then we evaluate them for IPT and initiate them on IPT. At the bottom of that card, we have the IPT, where we document IPT outcomes. And at the back of this pink card, we have ADR monitoring tool that is used to evaluate patients for pre-existing potential adverse drug effects that relates to isoniazid preventive therapy. So we also have an IPT register that is used to capture data, including demographics, drug collections, and outcomes for patients who are on IPT. We have a reporting tool, now no longer an interim tool, but now part of the DHIS tool that is used to capture IPT update data for entry into the DHIS tool. Next slide, please. Next. Okay. So why do we need IPT or TB prevention among women? We look at the national TB data, and like in other parts of the world, TB in Kenya is predominantly a disease of the men. Majority of TB cases, like over 60% being occurring among men. But when we look at it from a different perspective, from HIV perspective, we saw that the proportion contributed by women to HIV TB cases goes up from 38% in all cases to 47% among TB HIV cases. But again, looking at it from the smear positive TB, HIV, TB, a similar proportion, that is 46%, is contributed by women. So women living with HIV contribute a larger proportion of TB cases to TB HIV cases compared to what women as a whole contribute to general TB cases. Again, looking at it from HIV negative TB among women, they contribute, women aged 15 to 45, these are the women in the reproductive age group. We realize that this population contributes only 22% of all HIV negative TB. But when you look at it from the other perspective, from HIV lens, we realize that they contribute a higher proportion to HIV TB, that is 35%. So we really need to think about what we could do for our women, especially those in the reproductive age group, to ensure that we prevent TB among them and among their children. Next slide. So what is the package that we have for women and children in terms of TB, HIV? One, I would say, like in Uganda, Kenya has an integrated TB, HIV services, where majority of TB clinics and HIV clinics offer either services. So we have over 90% of our clinics offering TB, HIV services in integrated version. So in MCH, we offer BCG for the infants. We do TB screening as part of the routine. That is in line with our latest guideline for PMTCT, TB screening for women and children. For those who are diagnosed with TB, we provide them with TB treatment. And we also do contact tracing for children who are aged under 5 years old who are exposed to bacteriologically confirmed TB. We also provide IPT for eligible patients who do not have symptoms of TB. That includes children and mothers who are living with the HIV, and children under 5 years of age exposed to smear-positive TB, regardless of their HIV status. We also have a family approach to HIV care, and that means that if a mother who is in HIV care becomes pregnant and has to move to the MCH for PMTCT services, she moves along with her children who are HIV positive, so that they receive ART services from MCH to make it easy for the mother to attend the clinic and get services for both her children and herself. TB infection control is just part of the standard package of care for HIV, TB in PMTCT setting. Next slide. Next slide. So basically, I pulled this data from DATIN for TB screening and IPT for people living with HIV in Kenya. We have a total of about 1.1 million people currently on treatment in Kenya. And of these, from the data that was reported, about 90% of those were screened for TB, and close to 60% of those have ever been initiated on IPT as of the reporting date. Next slide. So this is how we've scaled up IPT in Kenya from the year 2014 to the end of the year 2016. I didn't include the 2017 data, but this is much higher by now. We have had a rapid scale-up of IPT from the first quarter of 2015 after the national launch of IPT. And in 2016, early 2016, we had the HIV treatment acceleration initiative, where we were trying to put all patients who have been diagnosed with HIV on treatment. And we actually integrated this as part of the treatment scale-up initiative, which helped us to spur numbers to the current over 600,000 patients being on IPT nationally. Next. Next slide. Okay, thank you. Oh, no, back. Okay. Now this slide, basically we take this from CDC-supported sites in Kenya, and you can see that over time we have had a scale-up of IPT among women, HIV positive, pregnant and breastfeeding women, and children who are attending care in MCH setting, from a low of as low as 1% in 2014 through 10%, 15, and by the currently we have about 38% of women who are in PMTCT settings receiving IPT. Among the children, we have close to 40% of those of children who are receiving services in MCH settings receiving IPT. Next slide. Looking at children under 5 years of age exposed to smear-positive TB over time, we can see that from 2012 we had just about one. The first assumption we have close to 40,000 smear-positive TB patients represented by the blue bar notified in Kenya every year. And we do estimate that for each smear-positive TB patient, we have one under 5-year-old exposed to that patient. So basically, in terms of putting children who are exposed to smear-positive TB in Kenya, we have had a progressive increase from 1% in 2012 to about 23% in 2016, but still this is far below the number that we target to initiate on IPT. But looking at it by HIV status, you can see that the proportion of HIV positive, patients who are initiated on IPT has been declining over time. And this we attribute to the fact that we have been mopping up children who we have had treatment mop up of HIV positive children. And most of these children who are already in care have been initiated on IPT. So going forward, we have children only who are being newly identified as HIV positive getting IPT. But I think one thing that we, in as much as we have not met our targets, we realize that we have had close to 20-fold increase over time. Looking at the outcomes of IPT among pregnant women, we realize that close to over 96% of our mothers who initiate IPT complete the 6-month course of isoniazid preventive therapy. This is encouraging from the program perspective. Next. Looking at their children again, we had very few children in 2014, but as numbers go up, our treatment outcomes are becoming better with over 99% completing treatment. Next slide. Now, we looked at children who are HIV exposed and who turned out to be HIV positive, and looked at what the uptake of IPT in that population was, and looked at their outcomes. So we have the uptake of IPT generally in this population is much low.
Hi, madam. Hi.
It's much lower than what we expected, but we have very good completion rates. Again, this is an opportunity for improvement for the Kenyan program, and we are trying to work on this to ensure that we have a better uptake and, of course, improve the outcomes going forward. Next slide. So if you look back at what we learned through the IPT program implementation in the country, we realized that it's possible to integrate TB services in PMTCT settings, and scale up of IPT with very good outcomes is possible in PMTCT settings. Involvement of our implementing partners was very critical in supporting this program. And having IPT integrated as part of the standard HIV treatment package is one of the success factors in ensuring that we have strong program and commodity security is maintained. Again, leadership of MOH, the Minister of Health, was very critical in implementing our IPT program in PMTCT settings. Thank you.
Thank you, Herman, for that great overview of the experience in Kenya. So we are a few minutes past the time that our webinar was supposed to end, but we want to stay on the line for hopefully another 10 to 15 minutes if you're able to answer any questions from the group. And I'm going to start with the few that were typed into the chat box. The first question was directed towards Steve. And the question is, what approach and which entry points would you advise to screen adolescents for TB, especially in a healthcare system where adolescent health services are centralized at tertiary health institutions? Steve, or any other presenters as well?
Yeah, I mean, I think that's a great question. I think that clearly, as a start, I think adolescents living with HIV would be an important entry point. Beyond that, I think it's difficult. I think adolescents who develop TB are going to present to either child and adult health services, as you know, in most TB endemic settings, there are not specific adolescent health services. So, I think it's challenging. So I'd be interested to know what other people think.
Thanks, Steve. Maureen or Herman, would you like to add anything about screening for adolescent TB?
Maybe to add, of course, the adolescents with the HIV is a critical point. Uganda has made very great strides in improving our adolescent services, and we are now pushing for adolescent-friendly services. And at implementation level, we have established what we call adolescent-friendly corners that have improved the access to care for adolescents, because this is a special group that really needs special attention given the challenges that they go through. So you find that facilities have been able to identify friendly corners for these adolescents, and for us that is a critical point to really integrate TB service delivery.
Yeah, again, like Uganda, in Kenya we are trying to strengthen adolescent services, and I think one thing we do for HIV services, we ensure that all adolescents are screened for TB. And the other thing is getting adolescents to know their right and actually demand for screening services for during their HIV clinic visits. We also have what is called Operation 000, which is an asset building initiative where we try to get the adolescents that get better to their treatment, reduce the missed clinics, missed pills, and so forth, just as part of improving the package of HIV care and treatment.
Thanks, everyone, for your thoughts on that question. And I'm going to move to the second question. This was directed towards Maureen. You mentioned the importance of good quality data to inform policy and programming, and the challenge among providers in documentation. There's a severe reporting burden on providers, which may be contributing to errors. Has the National TB Program considered integrating the reporting needs in the electronic medical record? And Maureen, if you'd like to start, and then if others would like to add, that would be great as well.
Thank you for the question. Just like Kenya, we actually have the DHIS2 running for TB. And in here, the data sources would be the registers or the documentation tools. And these are later translated to the reports, and the reports are entered into the electronic system. So we have started capacity building for health workers who really do the recording, and are also expected to generate the reports that are entered into the electronic system. So yes, Uganda has moved into electronic TB reporting. Thank you.
Great. Are there any other questions from participants on the phone line? Please feel free to type them into the chat box or unmute yourself. As you're thinking of your questions, we just saw another one that came in, and maybe Steve, you can answer whether there's been any progress on vaccine development for TB. Steve, are you there?
Sorry, I just unmuted. What was the question?
The question is asking about whether there's been any progress on vaccine development for TB.
No, not really. I mean, I think vaccine is an important issue, but I think it's difficult, and I would suggest that what we need to revisit is the issue of vaccinating early adolescents, again, because we recognize that there's a sudden increase in disease burden in late adolescence, and we recognize that giving vaccines to newborns has limited efficacy because of the immature immune systems of the newborns, and we understand that giving vaccines to children who are older with more mature immune systems did seem to have better protective efficacy and more prolonged efficacy over 20 to 30 years, such as was the case with in the UK. So given the rise in TB cases in the late adolescence, I think there is a case for revisiting the issues of vaccination for children who are at the end of primary school age, and that could be coordinated with other vaccine initiatives such as HPV. But I think there's need for more studies in that area. And so, it's an area of requiring more research. But there is a good rationale to think that we need to revisit the issue of vaccinating children at the end of primary school or early adolescence.
Great, thanks, Steve. I'm going to pause for a moment just to see if there's anyone on the line who'd like to ask a question. Okay, I see one more question. Oh, yes. Please go ahead. Could you say your name and then ask your question?
This is Eric Wabudea. I'm calling from Uganda.
Eric, hi.
Hi. Just to ask, especially the Kenyan colleagues, the experience about IPT. We have seen very high completion rates, as high as 99%. And this is in the HIV setting. So I just want them to give me an answer for two questions. One, what toxicity levels have they seen with INH? Because we've seen a few children with INH toxicities here, and there have been a challenge. So it'd be useful to know what experience they have on toxicities. And secondly, if they can make any comment on how how IPT is going in the non-HIV settings.
Hi. Now, if I'm able to take the question, I think we in CDC supported projects, we track INH toxicity. We ask our partners to report the outcomes together with toxicity. And I think from the data I looked at is about 0.05 of patients will report INH toxicity. And of course, sometimes, especially if you're treating patients who are well and you get them having toxicity, it raises concern. And we have tried to address this by developing messages which we pass out there regarding the benefit of IPT and the expected toxicities. So we don't let the patient expect that they'll not have any toxicities, but we prepare them to have such, of course, to expect and manage them appropriately, get them managed appropriately. Regarding IPT among the non-HIV positive patients, we have only children under 5 years exposed to smear-positive TB. We are starting a prisons program. The data we haven't really collected and analyzed it as the program is still in its infancy, but it has not picked very well as it has done in people living with HIV.
Okay, thank you.
Eric, I have to say that isoniazid preventive therapy is standard of care here in Australia, and whenever I've used it in other contexts as well, I haven't seen any serious adverse events, and I think that reflects the reality of the fact that it's actually a very, very safe preventive therapy regimen. Similarly with three months of rifampicin isoniazid regimen. But I do understand people's concerns. I think the difficulty is to try and suggest to a family that your healthy child needs medicine every day for 3 or 6 months or whatever it might be, and while trying to reassure yourself that this is actually very safe, because and so I actually think it's I think the evidence is very strong that it's that the benefits well outweigh the risks, but I think it's an ongoing issue that we have to always address, is the concerns about safety.
Thanks, Steve and Herman, for your thoughts on that. And Herman, we have one other question, I think, from Maureen to you. If you could talk about what factors have contributed to the greater than 90% IPT completion rates in Kenya beyond just supplies.
I think one of the issues, dealing with mothers and their babies, it's very easy. Once you tell a mother that something will benefit their children, they ensure that the child gets the benefit. Just like HIV testing and in those settings has high, anything else that is beneficial to the mother and baby pair is quite, the uptake is quite good. The other thing is the routine, the focus on ensuring that we retain people living with HIV in care. I think, again, that is one of the contributors. Better follow-up and tracking of patients who are initiated on ART and care. I think that is the other thing. But I must also admit that there's potential selection bias for patients who are more likely to adhere, because one of the criteria for IPT initiation is the fact that a patient is already having good adherence. So probably, again, that is one of the contributors to very high retention and completion rate.
Thank you. So in light of the time, I see that we have one more question in the chat box, and we'll make this our last question, and it's to Steve. Steve, what is your comment on task shifting of TB screening services as part of promoting TB integration? Leaving it to clinicians may affect success and implementation. Do you have any thoughts about that, Steve, or others as well?
I think that I think in terms of screening around children who are vulnerable for TB in households where there's a TB case, etc., I think whether it's detecting TB or whether it's providing preventive therapy, I think it's about decentralizing as much as we can. And I think that my view in terms of task shifting, and I understand the problems of task shifting everything to the community health worker, who's already very busy and not particularly well remunerated, etc. But I do think that the person who's supporting the family and providing TB treatment support for the TB case is definitely the right person to take up the task of doing this contact screening and providing support for those who require preventive therapy. So it's a family, community, integrated activity.
That's great. Steve and Maureen or Herman, is there any final thoughts that you'd like to add on that point?
Thanks to be for the. Go ahead.
Go ahead, Herman. Okay.
Okay, what I wanted to add is that the task shifting can be at I would say 2 levels, at the health facility and in the community. We have seen a task shifting at the health facility increase the number of cases presumed for TB. We have people like the health educators, the facility linkage staff, a few community health workers do the symptom screening while the patients wait to see the clinician or the other service provider. And this has improved the number of cases of presumptive TB cases that are later linked to diagnosis and really treatment thereafter. In the community, as Steve said, the VHTs or the village health teams really have a lot to do, and we need to think through how best to help them, given that these are just volunteers without a monthly salary or stipend. So we need to go back to the drawing board and see how to improve services while taking into account that they have different disease program priorities to take care of, and that might impact on the quality of health that they give at the community level.
Thank you, Maureen. And Herman, did you want to add any final comments on that?
No, I do not have any more comments. Otherwise, thank you very much for the opportunity to present.
Thank you as well. Thank you, Herman, Maureen, and Steve, for these excellent presentations. We really appreciate everyone's attention and interest in this topic and thinking about how TB and HIV programs can work together to support people throughout the life cycle. We're sorry that this went a bit over time, but we're happy that many of you could stay. We know we didn't get to everyone's questions, but we, Anna Dutchton and myself, would be very happy to follow up with anyone by email, and we'll ask Jessica to share our email addresses along with the link that will come out to the recording of this webinar. Jessica, I'll turn it over to you for any final comments from your side.
No final comments, just a thank you to everyone for joining us and for your active participation. And like Serbi said, we'll be sending out a follow-up email with all of the PowerPoints linked to the recording and all relevant resources and information.
Thanks, you.
Thanks, everyone.
Thanks, Jessica.
Thank you. Thank you to all the presenters. Thank you.